the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, Dr. Casey, and thanks for being on the podcast again. I really appreciate your time and taking some time to talk with us. Last time we went over upper extremity fractures in pediatrics and management, and I just wanted to go through some common lower extremity fractures I've seen in clinic and kind of pick your brain on how you manage those. Toddlers fractures, and you had touched on this when we were talking about the upper extremities, and I've seen these so many times, and it's exactly what you said. Some kids in somebody's lap going down a slide and whoops. And back to the NATs, tibia shaft fractures are real common. What about fibula fractures, diaphyseal fractures? And how often do you see both bone fractures in peds?
It's not as common for sure. Sometimes when it's an impact, so instead of the typical toddler fracture, which is a twist, but more of an impact where you kind of get a buckling of the distal tibia, sometimes you'll have a buckling of the distal fibula as well. But for diaphyseals, that toddler mechanism, in that age range, usually the fibula is intact. And a lot of times you don't even see a broken tibia. You hear the history, and the child won't walk, and even if you don't see the fracture, you just treat it like a toddler fracture. Which, interestingly, nowadays we've learned we don't have to be very aggressive with treatment at all. I think it's more treating the parents, honestly. There was just a paper presented at our Continental Orthopedic Society meeting for Peds Ortho. It said you didn't have to put anything on them. So you don't have to splint them or boot them or cast them. You can do nothing, and the outcomes are the same. So I feel like when I have a toddler fracture, I'm just treating the parents, and I let the parents decide, because if you don't, then they're going to come back and say, wait, we need this. And they know their child and their child's pain threshold and their child's, crazy behavior. And if they're worried and don't sleep because they're worried their kid's going to break it worse or something, I just let the parents decide.
It's kind of like if it's the first kid, let's do everything. If it's the fourth kid, do we have to do this?
You're absolutely right. Yep. And you can get a pretty good feel from the parents. The one thing you don't want to do is you don't want to put on a splint and break down their heel. So that's the worst thing that I've seen, is coming from the ED, a splint with no padding on the heel, and the child screaming, and nobody takes the splint off. And when they see me, their heel is worse than their tibia. And I have a patient who has a hole in his heel. His tibia is perfect, but suffered long term because of the splint.
Sure. And it can be a challenge to get the cast on if the kid's losing his mind. Ankle fractures, and there are tons of ankle fractures, and I don't want to talk about categorizations or any of that sort of thing, but I just wanted to ask you a few common ones that I've seen and a couple that I haven't seen that much, maybe a couple of times. So all the time I get the non-displaced Psalter 1 distal fibular fractures. They don't hurt over the ligaments, it's right on over the bone. And then Psalter 2's fibular avulsions. Is it just case by case, kind of the same thing, seeing what the parents think, a splint of some sort, cast? And then medial malleolus fractures, we talked about bimal, trimals, don't really see those that often. So what do you think about those?
So I think the distal fibula, you're right, it's super common. That's kind of the pediatric ankle sprain. And I usually just stick them in a boot. I never cast them. I usually just stick them in a boot for comfort, and they don't even have to follow up. So 2 to 4 weeks in a boot. As soon as it stops hurting, then you don't have to wear the boot anymore. If in 4 weeks they're still not doing well, then of course it can come back. But those are pretty straightforward. Medial malleolus, though, those are typically operative. Not always, but I think that decision definitely needs to be made. So it's not one of those where I guess if it's 100% non-displaced, then you can leave it. But a lot of times they kind of can behave like a lateral condyle, where they're just a little bit displaced, but they don't heal. They take forever to heal. Medial malleolus, we tend to fix those. And by nature, they're going to be either Psalter 2s or 4s, or, they're going to be a little more substantial. And a growth arrest in the medial ankle it's a big deal. So I think make sure you have that conversation about, it just depends on the mechanism, how severe the injury was, but that growth arrest is a big deal. And I do think it's worth mentioning the transition fractures. And when I say transition, that just means as the growth plate closes, you get these different patterns. And one is a to low. And so you really need to look for that one. And that's where the anterior lateral portion of the tibia gets pulled off by the ligament there. And if those are, displaced more than a couple millimeters, then that's worth fixing. And then, of course, the triplane, which is, looks like a Psalter 2 on the lateral, looks like a Psalter 3 on the AP, which makes it a Psalter 4. And so a lot of those are non-displaced and we just leave them alone. But sometimes they're displaced enough or they can fool you. They can be rotated and you can't tell that much. So those are ones that, honestly, if you want to fix it, get a CT scan. If you're too busy and don't have time to fix it, then don't get a CT scan. No, I'm just kidding. But just if it's more than 2 millimeters.
Got it. Okay. I had one of those probably a year or two ago, and we have a foot and ankle guy in clinic, and I said, this looks funny. What is it? And so he told me about it. I wasn't aware of that type of fracture before that, so I read about them in the past. Do you cast? Do you cast much? Short leg versus long leg, or do you use boots? What's your thinking on immobilization of the lower extremity?
Yeah, that's a really good question. I will have to think about. I think in clinic, I probably boot more. In the OR. Post-op, I probably cast more. Things that earn casts are like the axial tibia fractures in a 7-year-old. That's going to come in a splint. That gets a cast. It gets an above knee cast. But distal tibia fractures, those get a below knee cast. So if it's, in a 7-year-old, we're not talking the toddler fracture. We're talking actual something going on in a, I don't know, 7 to 15-year-old, but it's not, it's non-op. Those will get a cast for about a month before I switch to a boot. But lower extremities, I think we put on a lot more boots than casts in clinic for those, but I do a lot of casts in the OR.
All right. So last in the list, foot and ankle, and we talked about the ankle, but I don't really see that many tarsal or calcaneal fractures in peds. I just haven't. I, see a lot of foot fractures, metatarsals, base of the fifth, and I wanted to kind of talk about that more because of the physis that's there. Many times, and I'm sure you see this, oh, they've got an avulsion fracture and it's, normal anatomy. But I've also seen those that are pretty displaced when you compare to the other side where they've had a fracture. And I was hoping you might talk about that a little bit and tell us your thoughts.
Sure. Yeah. I think being mindful of the fact that frequently it is normal anatomy is great. I've had tons of people come in and say, oh, they were worried about this. And then the pain is like on the other side of the foot. So recognizing that avulsion, potential avulsion fracture of the fifth may or may not be actual avulsion fracture. Obviously, if clinically it's an avulsion, then it is. Sometimes I'll get the other side just to appease parents and say, oh, look, there's a piece over here too. I've never fixed an avulsion fracture in a kid. They just don't pull off far enough that they need to be fixed. Even the ones that kind of are intra-articular. So there's the tiny little avulsion that just looks like the fleck that's the normal growth plate. Then there's the actual fracture avulsion that pulls off, intra-articular. And then, of course, there's the Jones fracture. And even Jones fracture in kids, if it's non-displaced, I give that a chance to heal before talking about screw fixation. That's debatable, though. So there's definitely literature that says treat them like adults, but there's also literature that says not to. So that one's a little bit confusing. I think the main thing is to think about mechanism and just don't miss things. Like don't miss a Liz Frank in a kid because you're just not thinking about that. At least they're so rare. I'm not. And I've seen 2 in the last 2 years that, nobody got a weight bearing film and it was Liz Frank. And so just have your adult hat on sometimes too, if the mechanism is right, forced plantar flexion for that Liz Frank.
I should have put that in the discussion here because I did see one of those a few years ago. A competitive diver, was a kid and came down as the board was coming up, and the foot was really, really swollen. I did another interview with foot and ankle doc. He says, well, it doesn't necessarily have to be that swollen, but the couple that I've seen, I mean, it was obvious something was going on more than a sprain. So thank you for including that. The little toes, the little piggies there. I'm assuming similar to adults with the crush injuries and the stub toes and the fractures. I mean, you just kind of put them in a boot or a shoe and walk it off, and eventually it heals, right?
Yeah, pretty much. Just make it straight. If it looks crooked, then pull on it and make it straight. Yes, I agree. Little tuft fractures and toes, just need to make them straight and make sure you're not missing a dislocation or something like that. Not much to do with those.
Not much to do with them. Okay. All right, Dr. Casey, have we missed anything? And thank you for pointing out the list, Frank. I didn't even think about that when I wrote this. It's a great thing. Was there anything that we missed that you see a lot of that we should maybe talk about or might be helpful for folks that are listening?
Don't forget about tibial spine fractures. So not necessarily the tubercle, but the tibial spine. So that's the kid ACL fracture. Just saw a 6-year-old with it. It's sometimes really subtle. So if you have an injury that they come in, this was a little gymnast that did a cartwheel and fell off the beam or something, and she had a big old swollen knee. And her radiographs, if you really look, you could see that the tibial eminence was just up just a bit, tiny little bit up. But those are easy to not see. So just keep that in your brain. Anytime you've got a swollen knee in a kid, something's broken, something bad happened. Either like the three things I think about, like I'm talking little kids. So I'm not talking about patellar dislocation kids or ACL kids. These are like 6, 7, 8-year olds with swollen knees. Something is broken. So you just have to make sure that you're really looking and feeling growth plates. Like you don't want to miss a physeal distal femur fracture or something like that.
Okay. A 9-year-old male recently developed pain over the lateral aspect of his foot at the base of the fifth metatarsal when he plays soccer. He says it has continued to swell and he has pain with weight bearing. He thinks it started after he rolled his ankle several weeks ago, but he's not sure of any other trauma. He presents with his dad, who states his son is the next Carlos Valderrama. How many of us have heard that or similar? And he wants him to play as much as possible to keep him in soccer shape. As such, he did rest it, quote unquote, for a long weekend, but as soon as he started playing again, his pain recurred. An x ray is attached. What do you think this injury is? And are there other possibilities? And what does the x ray show? And I know it's just one image. And what do you think is the most appropriate treatment for this person?
Well, so this one's a little bit more interesting because it wasn't an acute injury and then they come see you right after the injury. It was more of a developed pain recently kind of thing. So it's certainly sounding more like an apophysitis. So the base of the fifth, more apophysitis type picture. So that's just irritation of the physis where the peroneus brevis inserts into the fifth metatarsal. And with the injury, the rolled ankle, that could certainly exacerbate it. And in terms of the x-rays, it's hard to know for sure because that can be a normal variant versus an actual apophyseal fracture because a lot of times it's a clinical diagnosis. So he's kind of skirting between two worlds here of apophysitis versus an actual fracture. But the thing that pushes me more towards fracture is the swelling. So it says that he had some swelling there. And so I wonder if he didn't just go ahead and have some antecedent pain and then pop that thing when he remembered that he rolled his ankle several weeks ago. And now it's just taken a long time to get better because he's not taking care of it. Fortunately, you don't have to take care of it. So he can decide if he wants to play through it and have a sore foot. And it may be sore for a really long time. Or if he wants to get better, then he needs to rest it. So I would rest in a boot for kind of 2 to 3 weeks. And if it doesn't hurt when you push on it after 2 to 3 weeks, then you can gradually, and this is the hard part and the key, gradually return to activity as long as you're pain free. And then hopefully it was actually a fracture that heals, and then he goes on to be the best soccer player in the world and doesn't have pain.
Sure. And I wanted to throw that in. Part of it's humorous because I see that parent, my kid's the next Michael Jordan, my kid's the next, whoever. And they're really not. And they're pushing the kid, and the kid's really not wanting to do it. How do you manage that? How do you manage parents and their unrealistic expectations of their child without being offensive or without sending them to some other practice?
Oh, it's such a good question. And it is a fascinating thing to watch. And you see it actually, you see sometimes it's child created. So like I would say in the gymnast population, they've been a gymnast for so long, like 20 hours a week. And when they're about 12 or 13, they start having a bunch of these injuries that I can't ever really see, but everything hurts and it just hurts when I do gymnastics and we get one better and then there's another one. And but what's interesting is sometimes it's not even parent driven. It's the child identifies their whole life as gymnastics and they can't they can't admit that they don't really like it anymore and they'd like to do something else, or they're scared to do that. So that one's an interesting dilemma that I haven't figured out. So if you have the parent that doesn't push, then sometimes I can bring them aside and say that. But for when it's the parent pushing, uh, it's really tough. And sometimes I think the best thing to do is just to ask the child, "Do you love soccer?" And if they're like, "Oh, yes, it's my life," that's a little bit reassuring. But if it takes them a second to answer the question, I kind of ask it several different ways in front of the parent to try to get them to recognize maybe their child doesn't love it as much as they think they do. And maybe there are other things to do for fun than just that sport.
Yeah.
But yeah, it's a really tough problem. Good question.
Yeah. If you can't handle the bruise on your arm in football, then maybe you should try golf, right?
Exactly.
Dr. Casey, thank you so much. This is great. I appreciate your time. Thanks for everything you've done. I'd mentioned this and the other, and I want to say it again. You're a great PA advocate. Come to our conferences. We really appreciate that. And
Oh,
I really thank you for your time.
absolutely. You know I'm married to one, right?
I do.
Oh, okay.
But
Just double checking.
yeah.
I'm
Well,
definitely an advocate. Love those PAs.
yeah, me too. Me too. So, all right, Dr. Casey, thank you so much.
All
Have a
right.
good rest of your day.
Thank you. You too.
Thank you for joining the orthoPAC podcast. Please follow the Physician Assistants in Orthopedic Surgery on social media. Connect with us on Facebook, Instagram, LinkedIn, and Twitter. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review. I'm excited to tell our audience that Denver registration is now open for our 22nd annual meeting. This is our annual fall meeting and will be August 22nd through the 26th at the Sheridan Denver Downtown Hotel. Come and join us for some CME and get away for a little while in the Mile High City. Stop by the desk and say hello. I look forward to seeing you there.